Today's module is on axial low back pain, commonly just called low back pain. Axial is our term for pain that stays within the body and does not radiate into the extremities, either the upper extremity, as in a pinched nerve in the neck, or the lower extremity, as in sciatica. Low back pain is a very common diagnosis. There's a tendency for primary care and other providers to be a bit minimalist about this, assuming the patient's low back pain episode will resolve within weeks. And while that is often true, it's also the rule that low back pain can recur, or when patients try to increase their activities again, they'll get recurrent symptoms. It's therefore important to try to be accurate with your diagnosis and to also rule out competing diagnoses which are more severe, such as sciatica or, for example, sacroiliac joint injury, which we touch on in other modules. We'll talk more about the diagnostic approach as well as treatment in the history and physical exam portion of this module. Thank you. The key about this diagnosis is that it's generally not very specific. It basically refers to patients who have pain in the lower back or near the lower back without radiation into the leg. Typically, these patients go relatively undiagnosed, and that might be okay so long as they're improving. As I've discussed already, sometimes even if they're improving, they will get recurrent symptoms, especially if they go back to their usual activities. In terms of physical exam, this is mostly a diagnosis of exclusion. Patients have fairly normal neurologic findings. They may have some other conditions that look like it points to a pain generator, but usually it's fairly nonspecific. When you have patients go through range of motion, I have Jennifer here, when they go into flexion, they might have some localized pain or extension localized pain, but usually nothing going into the extremity, as I mentioned. I'm going to have the patient lie down here. What we do in this part of the exam, we're still going to do the other tests we do for assessing the lower back. We'll do a straight leg raise. Usually if it's just localized back pain, they may have buttock pain, but it won't go into the leg. Again, we're going to screen for hip problems. So we put the hip into external and internal rotation. Sometimes external rotation in particular can cause some localized back pain. We'll move to the neurologic exam. Often these patients have pain and some weakness when I test the hip flexors. They're holding the leg up and I push down. But they're not going to really have a neurologic exam that's consistent with injury. Okay? And distal muscles such as extensor hallucis longus, EHL, that will be normal, ankle dorsiflexors normal, etc. And then typically I'd have the patient on their stomach, and I would also test their hamstring muscles and do palpation. I'm going to let Jennifer go here, and I'm going to move to our model. What we would find is typically tenderness in the lower back area, sometimes the paraspinal muscles. Note that we really cannot distinguish tenderness of the paraspinal muscles from the surrounding joints. They might have some tenderness into the PSIS area. Often that goes more with SI joint injury. The key with this diagnosis is that there aren't any solid neurologic findings. And again, this often gets better, but if it does not, one needs to consider more of a workup. Let's say the patient has low back pain. It's worse with sitting. It doesn't really go much into the leg, but then they take a long flight from Seattle to Florida. And by the time they get to the other side, they have a lot of pain going down the back of the leg, even into the calf. They say, oh, I notice now it's actually tingling in the calf. Probably what they had was some discogenic pain and a tear in the disc, but not a full disc herniation. And now this is getting aggravated. And so when you see the patient in your office and you do something like a sitting straight leg raise, you start to know maybe a little pain back here. And then when you bring their head down, it'll start to travel there into the calf more, aggravating their pain. And now you sort of have a bit of an answer that could be discogenic pain. In terms of treatment, you still may not do much than conservative care. Physical therapy, chiropractic, massage, those are all excellent modalities. We do some dry needling in our office. But again, if things start to progress and get worse, then we start to get fairly diagnostic with specialized injections, etc. Generally, this is not a surgical diagnosis, although you could probably find somewhere in the country where someone's doing surgery for this, but it's ill-advised. One last thing I want to say is you should watch for the red flags. So especially older patients, if they're waking up in the middle of the night with severe pain, if they're losing weight, if they have a history of cancer, and when I say losing weight, I mean when they don't mean to, And if they have pinpoint, central bony tenderness, you should start thinking about a pathologic fracture or a tumor or something like that. Extremely rare, but you don't want to miss this. Also, occasionally in the older patient, they might have osteoporosis, and even opening something as simple as a window that's stuck may cause a compression fracture. But those are relatively rare, at least in my practice.